Hello, welcome everybody to Grand Rounds. I'm Kaz Nelson, Vice Chair of Education for the Department of Psychiatry, and it's my distinct pleasure to invite invited lecturers from the University of Washington today to talk with us on a really critical education-related topic. And the reason for my excitement is this is our second ever invited lecturers that we've had on the topic of education. A few months ago, we invited Donna Sudak to talk to us about supervision in therapy. And so we're hoping to keep this trend going twice a year to invite national leaders in the field of education to share with us best practices and trends in order to invest in our teaching and training of learners and learning ourselves. And so I'd like to tell you a little bit about our speakers today, which we're very honored to have joining us. Dr. Jesse Markman is Assistant Professor at the University of Washington Department of Psychiatry and Behavioral Sciences. He serves as Associate Residency Training Director for Acute Care Services at the VA in Puget Sound. And we also have Dr. Heidi Combs, who is an Associate Professor at the University of Washington School of Medicine in the Department of Psychiatry and Behavioral Sciences, and has completed the Master Educator Certificate Program. Both of these speakers are highly honored in terms of their teaching and their awards that they've had in teaching, and they're friends of ours in our work at the Association for Academic Psychiatry, a national group and conference that our department's really been active in the past couple years, and starting that trend and starting to network and make some of these relationships. I am really looking forward to the conversation today, and we'll save a little bit of time for questions and conversation. But I wanted to issue a couple thank yous first. First, thank you to Laura Wixer, one of our psychiatry residents who attended AAP last fall and was, even the previous year, and was instrumental in making connections with our lecturers today and led to this invitation. And I also want to thank the departmental leadership team for allocating and dedicating Harold Lond funds in order to support this visiting lectureship today. So without further ado, we can get started on our talk. Thank you.
Thanks, Cass. So my name is Jesse Markman. Heidi and I are really excited to be here today. I actually grew up in Minnesota, and it's really nice to come back and get cold for a little bit. And a special thank you to Laura for making that connection and helping us come out here. So we are going to be talking about a few different things today, and we are going to go a little bit all over the map, but hopefully come to a single destination at the end. We're going to have time for questions at the end. We're happy if you have a burning question in the middle. Please feel free to ask. We can be very flexible with our time and how we're going to be talking about things today. So I'm going to be spending some time initially talking about medical student mistreatment and a study that we did at the University of Washington and how that relates to teaching and how we think solutions to issues with continued medical student mistreatment could be solved by focusing on teaching education skills. And then we're going to spend some time talking about sort of the value of a clinician educator track and program and how you can support the development of clinical teaching and clinician educators in your institution. We're going to review some strategies that worked well at the University of Washington, some challenges that we found, and then we're able to overcome because we know that your clinician educator program here is a bit younger than ours. So hopefully that will bring up some interesting points and thoughts, and we'll have some discussion after that. So to talk a little bit about medical student mistreatment, so this is really not a new concept at all. And so studies of this really started in about the 60s. So if anybody's unfamiliar with this, this would be sort of treatment of medical students would be averse to their educational progress and problematic behaviors ranging from as potentially straightforward as feeling publicly humiliated and as wide-ranging as potentially physical or sexual abuse. Studies in the 80s were some of the first that actually developed some rates of this and found rates as high as in the 90%. And that was pretty remarkable at the time. And there were actually pretty significant progress, but the medical student mistreatment really hasn't disappeared. It's been a pretty consistent thing. In 2012, rates were 47% of students sort of stating that they had experienced some form of mistreatment during the medical education, and most students tend not to report this. Okay, and despite interventions, there hasn't been really the reduction that one might hope to see. So I would consider 47% still being higher than I would hope for. And so if we think about why does this matter, right? So medical student mistreatment has been shown to lead to all kinds of negative things. It can lead to actually causing medical students to change their medical specialty and go into different areas of medicine, which leads to problematic drinking and physician burnout, potentially depression, often avoidance of clinical teaching, and actually consideration of just dropping medicine altogether. Okay? And so this was something I was pretty interested in when I was a resident, and so worked on developing a study to try and investigate this a bit more. And the thing that I was particularly curious about was, we don't know a lot about some of the aspects of mistreatment, of what actually makes something mistreatment. So the most common form of mistreatment in 2012 was considered public humiliation. And we don't really know what makes something publicly humiliating. We don't understand from the survey of graduating medical students what causes an experience to be public humiliating or not. And so that was really the impetus for this. And another thing that happened in 2012 was that the graduation survey that all medical student graduates get, that everybody in this room, well, probably not everybody, but a lot of people in this room completed themselves, used to ask, did you experience medical student mistreatment? It was a yes or no question. And if you hit no, you didn't have to answer any other questions. And if you hit yes, then you had to describe a bit about it. And in 2012, that changed, and it literally just asked you about each individual aspects of mistreatment. So did you experience sexual harassment? Did you experience physical abuse? Did people ask you to perform favors for them? Did you experience public humiliation? And when asked in that way, the rates of mistreatment grew from in the teens in 2011 to 47% in 2012. So this was pretty exciting. And at the University of Washington, our rates of mistreatment were higher than the national average, which terrified the dean's office a lot, right? And so they were really excited to spend money on a study. And so they were interested in funding the study, which was fortuitous for me. So going into this then, we wanted to do a qualitative study focusing on focus groups of medical students. We actually had a lot of trouble collecting data in terms of getting volunteers to participate in our focus groups. And we weren't entirely sure why, and we're still not sure why, but it took us a long time to collect data. So we actually collected data from 2013 to 2015. And we collected data mostly from third-year medical students. Most of them were participating right before the start of their psychiatry clerkship experience, because we learned that in between clerkships, before anybody has any work to do, you're most likely to get success in using food to coerce people to participate in a focus group. And it didn't matter sort of what other terms of advertising we did or coercion, but this really worked the best for us. And so we had groups of, usually it was somewhere between 3 and 9 medical students. And we had focus groups that were facilitated by a moderator and a co-moderator. And we asked some of the following questions. So things like, did you experience public humiliation? If you did, what was that experience like? Where was pimping fitting into this experience of public humiliation? Did these situations vary between locations or types of rotations that you were having? Trying to really understand what we could about this. And so we collected all of our data. We audio recorded all of our focus groups. We transcribed them, and then we coded them with 2 independent coders who did different levels of coding and then discussed the results. We actually had remarkable agreement, which was nice. And then if we take a look at the results, so if we think about what public humiliation is, I was actually surprised that the medical students who were participating were really pretty good at describing what they thought public humiliation was and separating it from other potentially like terms. So I thought there would be a lot of confusion between embarrassment and public humiliation, for example. So if you're embarrassed in a teaching situation, I thought students would then be likely to say that that was public humiliation. And they were actually really clear and consistently clear that embarrassment was an internal experience that they felt that was self-caused, that they would feel embarrassed because they didn't know something, but that was their own issue. And that public humiliation really came when they felt like their teacher was causing them to feel embarrassment on purpose. So that they didn't feel embarrassment because of something they did, they felt embarrassment because of something somebody else did. And they also separated it quite significantly from abuse. That there were very clear instances when they would experience abuse, but they would not think that was public humiliation. And they considered abuse and humiliation under sort of an umbrella of mistreatment. Okay. So then we were curious about sort of what risk factors for public humiliation would look like. And one of the most significant or consistent risk factors that we saw was really the perceived tone of the teacher. And so students were very likely to make assumptions about teaching situations that they had and assumptions about the intent of the teacher. And if they assumed that the teacher had or did not have their educational interest at heart, they were much more likely to perceive the experience they had as publicly humiliating because they assumed that the embarrassment was forced. What went hand in hand to this was the perceived intent. So if they felt like they were being asked questions to, for example, demonstrate that they did not know anything, then they were more likely to experience this as public humiliation. And so what was pretty interesting about this to me was that the students were very quick to make perceptions and make assumptions about the intent of their teachers. So in asking a bit more about that, sort of what would make those riskier, that people said that they were more likely to feel humiliated if things were quote-unquote public in terms of being in front of patients. I actually thought that it was going to be public in front of their peers, that if somebody didn't know something in terms of their peers in sort of a rounding clinical teaching example, that they would be most embarrassed by that. And they actually said that they felt they would be most likely to be humiliated in front of patients because they were working very hard to be seen as the physician, to be seen as the primary provider for that patient. And if they didn't know something or there was an experience that made them feel embarrassed or humiliated, that it would be because the patient then would lose trust in that experience. We also found that procedural experiences were a pretty high risk factor. And there's some interesting literature. There's not a lot of literature written about this, but there's some literature written by a surgical department that they really thought that students were likely to experience mistreatment in a surgical arena because they were afraid of harming patients and it was a high-pressure situation. And I actually, the study didn't investigate this, but I had my own theories about this, which is that a procedural experience is typically very impersonal. So frequently, if you're meeting people in the OR, you may have not met them before, or you may have met them before, but they have not remembered who you are, and you're probably only seeing about this much of their face because they're gowned and gloved, and they have masks on, and it's extremely hard to make any interpretations about the intent of the teacher if you can't read their body language, if they're not looking at you, if they're doing something else. And I also hypothesize that they potentially don't do a very good job describing what the purpose of their questions or what's going on in the OR with the involvement of the student have to do with. So it's more likely then that you might be able to make some misperceptions. One of the things that the students were very clear to highlight that was that they found discrimination of any kind as really its own separate thing from public humiliation. So that we did have people who described examples of feeling discriminated against because of gender or perceived political values, and they really found that as entirely separate and not pertaining to whether or not they actually felt publicly humiliated, but really just its own experience. So I just wanted to include some quotes. So one student said, "For me, good things have just been if you can really sense that the person cares and wants you to do well. Once you get that vibe, then if something happens that's wrong, it's so easy to just say, just to change it and make it better." I think it can even just be a simple statement like, "I want you to be here. I want you to succeed. Let me know how I can help you." And another student said, "And I think the times that pimping went the best for me, so to speak, is almost when it was preceded by attendings that would say, 'Hey, look, I'm trying to teach you, and this is how I teach students, is I ask them questions, and you might feel attacked. That's not what I intend to do.'" So when we were thinking about things that were not actually risk factors and looking into the data, there were a number of things that were potentially surprising. So pimping is not a politically correct term, and so I will, although it's still what students use and talk about, and so we'll use it to reference Socratic teaching in a clinical situation. But medical students were very clear that they did not feel that Socratic teaching in and of itself was necessarily risky for public humiliation. And that it really had to do with how the orientation and introduction to the Socratic teaching happened. So that if the student was oriented to the Socratic teaching, felt like the Socratic teaching had a purpose for them, specifically to increase their education or increase their knowledge base, that they were very willing to be questioned and taught in a very Socratic way. Whereas if it was not oriented and came out of nowhere, they were much more likely to perceive it as publicly humiliating. But it wasn't the fact that they were taught in a Socratic way in and of itself that they found to be publicly humiliating. We were also pretty interested in location. So our School of Medicine is stretched over a 5-state region. So we have clinical rotations at, how many sites do we have? Yeah. Hundreds of clinical locations. So there's a really wide range of, we have rotations at major academic medical centers, and we have rotations where you're working with a single preceptor in a single town. And so we're really curious if people were more likely to have experiences of mistreatment or not based on the kind of rotation they were having. And this didn't really bore out in the data. It's not to say it didn't exist, it's just that it wasn't something that was actively discussed, and that there was actually a balance between statements from people saying, look, if you're in an academic medical center, it's entirely possible that the teacher may be less invested in you and might not orient you well, and you might have a poor experience. And also, if you went to a small community program where you were doing a rotation and there was just one preceptor, if things go well, it's a really great experience. And if you guys don't click well, it's a really, really poor experience. And so that was something that we just didn't see. We didn't see a difference between academic or community programs. We also didn't see a difference in who the offender was. And this is pretty consistent with the graduation questionnaire data that I talked about before. The mistreatment can come from physicians, it can come from, attending physicians, residents, it can come from nurses, it can come from patients themselves. And so what I think is pretty interesting about this in general is that the majority of interventions, at least in terms of what's written about in the literature, in interventions that attempt to reduce medical student mistreatment, focus on trying to change the environment of the clinical care in we need to raise medical student mistreatment or raise awareness approach, and then end the hostile work environment that we're creating. But it really doesn't focus on the idea that if you could educate people about the education process in a way to make them more effective in what they're trying to do, potentially you could be much more effective in reducing some more subtle forms of medical student mistreatment. So when I referenced before, public humiliation was 35%, so that was 35% of all comers, and only 47% of people experienced some kind of mistreatment. And so it's actually an enormous percentage of what was experienced. And I would personally consider it to be a bit more of a subtle form of mistreatment that is not necessarily coming from very overt sexual harassment, very overt physical abuse, the kinds of things that are much more easily targeted with a zero tolerance or a no tolerance policy. And so I think that this, the idea of trying to enhance the teaching skills of the preceptors could potentially be much more effective in reducing these more subtle forms of mistreatment. So specifically then, how would you do that, right? So if you demonstrate commitment to student learning, largely with orientation, really it's actually a pretty low time or low cost process in terms of time, that students will they'll be less likely to make negative assumptions about the intent of the teacher. Okay? If you're oriented, you can really participate in Socratic teaching, because we've had attendings who say, you're telling me I can't teach the way that I used to be able to teach. I've done this for years and years and years, and you're just telling me I can't do it anymore, so I'm just going to stop. And that's really not something that you have to do. You don't have to go away from that. You just have to do a different or a better job orienting them to the process. And that students really will be able to tolerate this. Okay? You need to be clear that unacceptable behaviors will not be tolerated. Okay, so I'm not saying that this is don't focus on the fact that sexual harassment is unacceptable, physical abuse is unacceptable, trading favors for grades is unacceptable. Those things are absolutely unacceptable. It's just to do this and to those things. But if you can make it clear that those behaviors are unacceptable, then students will feel supported. And I really think we've seen this in particular in our medical school, because we did our study over almost a 2-year period. We saw efforts from the dean's office as being receptive to talking about mistreatment, talking to students about it, that you really can have improvements if you have a persistent, concerted effort towards it. So when I've talked about this before, one of the interesting things that people have brought up is really sort of this idea that medical students are different than they used to be, that they're millennials now, right? And that they're soft, that they require too much hand-holding, okay? That they don't approach experiences in the same way, they're not as professional, okay? And they're just not what they used to be, okay? And I don't want to be too stereotypic, but frequently this came from attendings who might be older than myself. And so I think the thing to focus on is that students really are not what they used to be. So I remember thinking this, I want to say 2 or 3 months into residency. And I think a lot of people have that experience. And I'm pretty sure my parents thought that about me. And I'm pretty sure that my grandparents thought that about my parents, and so on and so forth. That the previous generation has always been better than the current one, has always worked harder, and has been more successful, and that is simply the way it is. It's not necessarily a bad thing that students aren't what they used to be. This is not necessarily negative. I mean, we're very good at not blaming the consumer for being upset about a product when it's, if you're unhappy with your iPhone, you feel very justified in being upset with Apple for creating a product that you don't like. And Apple does not turn around and say, consumers are not what they used to be, we're done, right? And we are creating a product for people to consume. And that if they're upset with that, then we need to think about why. So I think students are much savvier than they used to be. They're clear about what they want, and they're clear about what they don't want. And I'm not to say that there aren't differences in the way that people approach things and conduct themselves in a professional way, but that this isn't necessarily something to just say, look, we have a bad batch for this generation, let's wait till the next one, things will get better. And I think as educators, we really need to adapt to this change and think about how does education need to shift. In as much as for all the people who I've heard say this is potentially a generational problem, none of them have said, hey, I really wish people went back to Q2 call, never saw anyone, and did things as unsafe as I did, right? And we really have seen mistreatment rates reduce, some for really good reasons. I think we really do have less physical abuse, less sexual harassment in the hospital, and that's already been because we're changing to try and have a more appropriate learning environment and work environment. And this is just a continuing evolution of this. So I'm going to turn this over to Heidi at this point.
Thanks, Jesse. So has education changed? Oh my goodness, yes it has. So I had an opportunity to spend some time with a reunion group from the University of Washington where my dad graduated from medical school. And the way they do it is they have reunions that are staggered. So the class of 64, 74, 84, 94, and 2004 have a reunion together. And I had an opportunity to visit with this group. And one of the things I asked of the group, and I'll ask the same thing of you, is in your medical education, when you were in medical school and you looked to see the lecture that was happening the following morning, and if you weren't particularly interested in what was going to be talked about, would you not show up? I want to raise a hand. How many people would not show up if that was the case? So none of you. So all of you were very compliant and good students. So when I did this with this group, first of all, the people that had graduated with my father in 64 looked horrified that I would even entertain asking that question. The folks that had graduated in 2004 raised their hand without even thinking about it. Because for them, they were not going to spend their time doing an educational activity that actually they didn't learn from. So it was a shift. It wasn't that it was right or wrong. It was different than what people did years ago. I think medical education is different. All of you, at this point, given time constraints, probably don't do activities when you have a choice if you don't learn from them. Is that true? Right. So that's what medical students do now. If they don't actually find a way someone's teaching them to be effective, then they'll find another way of learning because they have other options now that they used to not have. That's a difference. It's not right or wrong. It's just a difference. It's a different thing about medical education these days. And things do change, right? You think about you as a physician, how things are different. 1990s nerd, totally hip these days. Same person, just perceived in a different way. If you think about, for clinicians who have been working for a while, how different your work is now compared to how it was 20 years ago. Do you remember hearing about RVUs 20 years ago, about your productivity numbers? I'm seeing a couple people shake their head. Some people are looking at me like, what is she talking about? Did you think 20 years ago that your patients would be grading you? And that they would be shopping for you and deciding to come and see you depending on how other patients that worked with you thought you did in your communication strategies with them? This is different than the way things that were before. These are good things, not bad things. But the changes that have occurred, I think, make it even more challenging than it has been previously. So if you think about physicians are graded, your infections rates, if you're a surgeon, are evaluated, rehospitalization rates, how many people have looked at CHF data and when your patients bounce back, what that means for payment for your hospital within 30 days. These are things, are these good things? Yes, these are quality measures. Do they add stress to being a physician? I think the answer of that is yes as well. Productivity. So no longer are there the emeritus professors that get to come and chill out and chat about whatever they're most interested in chatting about, at least not in our academic center. There's not many of these anymore. People still have to sing for their supper. You have to maintain productivity. You don't get to just get to this place and then have freedom to do what you do. Academics is really not that way so much anymore. And as Jesse talked about, the people that we get to teach demand something from us now. We don't get to just do whatever we feel like talking about or doing the way we want to teach, because our learners will actually vote with their feet. They just won't show up if the way in which we're trying to convey information for them is not very effective. So I'm going to do a survey here. I'd like you to raise your hand if you have an academic appointment of some kind, and keep your hand up. Now I'd like you to tell me if you think keep your hand up if you think medical education is important. Now I'd like you to keep your hand up if you had formal training in how to teach. You can put your hands down. So half of the people dropped their hand when they actually identified did they receive formal education in how to teach. And I think that's the challenge, is we are asked to teach. How many of you were asked to teach in some capacity in your position that you have now? So many people in the room. So fewer people had their hand raised in saying that they were taught how to teach than people who raised their hand and said, I actually teach, or actually value teaching. And I think that's how come there needs to be a change. People identify, I think, that education is important, but with the competing issues that physicians face at this point, it has to be, I don't want to say more thoughtful, but I think a little bit more, there has to be more intent to allow this to develop for people. And given the importance, I think, of education, I actually think that I spend my time teaching the next generation of physicians how to do what they do effectively. I think that's a little important, right? I think that's a valuable thing that we all do. Because of that, then, we actually need to have support around that, given clinical productivity numbers that need to be met for those of us who work in clinical care, for those of you in research, grant funding that you have to do while you're going to be bringing research folks up and mentoring them. So if you actually want to have an education program be successful, you have to have it valued by your department, and you have to have support. And the support comes through time, money, commitment, rewards. You can't have, if you have lots of money, but you have no time to spend it, not so great, right? If you have tons of commitment, I bet if I actually measured your level of commitment for education in this room, it would be really, really high. However, if you get no rewards, you get nothing identified for the hard work that you do, at some point it becomes a thankless task when you have these other pressures that occur as well. So you really need to have your department support you in these ways, I think, for it to be successful long term. Because all of you know, how many of you remember when you first started teaching, how on fire you were and excited you were about getting to teach? And at some point, when all these other competing things start to get up on you, it starts to wane a little bit. So having these things present allows you to be able to do this in a long-term way. So things that our department has tried and developed and changed over time to try to improve the teaching of teachers and to promote the importance of scholarly activity around education is we have early education for residents, which I'll speak to. We have teacher scholars pathway for residents, the same for faculty, and then we have the clinician educator pathway. So I'll address each of these things. So this is kind of in a nutshell what we've done in our department. So Jesse came to me when he was a resident and said, you know, I have this challenging student, I'm not quite exactly sure what to do. How come we don't really ever get taught about how to teach students? I'm like, what a great idea. Fabulous. So Jesse approached our current, the then residency training director and said, we'd love to teach the residents on how to teach. So in 2010, we added that to the R1 didactics, which is now a repeated thing that we do for R1s. And for those of you who are a little further back from your training, if you think back to what it was like when you were a brand new R1 and you just finished being a medical student, and now you were the primary teacher for medical students, whereas the week before you were one of them, it's usually a very anxiety-provoking position for residents to be in, and they often really do a really good job, aren't quite sure how. So we added that to them, to their didactics early on. And then we also, as they go through their training, when they're going to be training junior residents on call, they have the trainer's workshop that they go through. Because again, teaching medical students is different than teaching your peers. So giving them skills on how to be able to do that effectively and improve their comfort in that. We also have education electives. So if I have residents in the program who are very interested in education, they can choose elective time and they'll work on projects related to education, oftentimes curricula, lecture series, whatever they're interested in, as a way to promote education. And then we also have rotations in advanced clinical teaching skills. We call them junior attendings. So they will come on the units in July or August, and they will run a team, and the attending gets to step back and be quiet and let the junior attending run their team. So these are ways that we've worked on incorporating teaching throughout the resident education. This is the teacher-scholar path that I spoke of earlier. So this has been in existence for now about 5 years, I think. So in our program, we have residents that can focus areas of interest like community mental health, addiction, psychiatry, and so on. And what about having something for residents who are interested in education? So Jesse and I were founding members, this is when Jesse was still a resident, for the Teacher Scholar Pathway. So it's a program that we have that they apply into, again, trying to show that this is an important thing, not just something you think, oh, maybe I'm interested in doing, so show some commitment to this. And then we have monthly meetings, and there's a didactic component, so there's a text we go through, and it's a yearly rotating didactic. So at the beginning, the junior residents, this is the first time they've heard it, but the senior residents, that it's their third year, for example, in the track, they become the mentor for the junior residents. So then the faculty back up more under kind of lifelines or something for asking questions. So it's really more resident driven at that point. It allows them to get mentorship. It allows them to practice in group settings, showing their work. Often we'll do works in progress, so they'll present something that's not quite there. They get feedback from the group. It's also a way for them to work on developing workshops like for AAP. We've had several groups of our residents in this track present at AAP because they got support from the whole group. And then they can graduate with an area of distinction if they choose to engage in this during their graduation. So we have this for residents. There's also something called the Teacher Scholar Program. This is actually not in my department. This is a University of Washington wide program. If you notice in the previous slide, formal applications, monthly meetings, mentorship, didactic, peer-led support, oh my goodness, they're exactly the same, which is part of the reason we've actually modeled ours based on this, because it was a very successful program. The difference being that the resident one I spoke of clearly is just for psychiatry residents, whereas this is for people within the University of Washington. So you'll have epidemiologists and surgeons and radiologists and psychiatrists all in this cohort that go through for a year. It's a really fantastic way to develop connections with other departments and to do collaboration if you want to do publishing. So it's a really nice way of making connections with folks that you would otherwise wouldn't make connections with. And this is a very popular program through the University of Washington. We also have the Clinician Educator pathway. So I myself am a clinician educator. This is not your backup plan. You don't choose to do this when you failed on your research track. It's like, well, okay, I didn't quite get all my grants, now I'm going to do this instead. The folks that are committed to this are devoted to scholarly work within the field of education. So part of the promotion requirements are that it isn't that you just publish, but that a body of your work relates to education in some way. Can be whether it's didactics or whether it's more studies like the study that Jesse was talking about related to education. So the only way that this will succeed is if you have department support, because you need to have some time carved out to be able to do the work that you need to do, which is very difficult in the climate that departments have these days and all the pressures that they have. This is not just a pathway for those because they teach. Anyone who works in an academic center signed up to teach. That's part of the deal, right? So that isn't make you a clinician educator track person. It really is a primary focus of what you do, makes you someone that's on a clinician educator pathway. So some challenges we've faced in our department regarding this. You can't compromise on finances. I'll talk about that in a moment. Formal mentorship is essential, and qualified candidates need to be successful in promotion. So these are keys to having a successful clinician teacher pathway, and your department has to support this. So no matter what, you still have to look at the money. Like really, it has to be something that your department will support, because we don't make money. Right? If I'm spending time teaching medical students, if I'm spending time developing didactics and doing scholarly work around education, am I billing for that? No, I'm not billing for that. Is it the right thing to do? Yes, it's the right thing to do. Is it important? I think it's important. But I have to have the support of my department in order to be able to do that, or else all of these other things that encroach on your time will take away from your ability to be effective. And this is reality. Right? Our departments are usually not flush. So you have to really think about the finances, and you have to find your department ways to support you in being able to do this work. Otherwise, you won't be able to succeed. Mentorship is huge. This is something that has been a work in progress for us. So we have a clinician educator pathway meeting. We have it. There's 3 primary institutions in the University of Washington: Harborview Medical Center, where I work, the VA, where Jesse is, and then the University of Washington. And each of those sites has their clinician educator meetings. The one at Harborview, I think, is a bit more robust because we have a kind of a critical mass there. We have a large service. We meet every month. There are these meetings are chaired. The expectation is you're going to show and you're going to contribute. You can do works in progress. We have people come and talk with us about what is the best place to get published. Do you know about MedEd Portal? How do you do an effective lit search? So we ask people within the pathway, what is it that you need to be successful? How can we help you be successful? And then if there's things that we can do within these meetings to support that, then we do that. The biggest thing you get from it is support. Misery really loves company. Suffering alone is not helpful, so it's really nice to have colleagues that you can get support from. We also have a mentoring program. The old mentoring program that we have was, I thought, very ineffective. Did any of you have a mentoring committee for you when you were going up through your promotion that was created, your promotion committee? So a couple of you have. So traditionally, these are several senior faculty that are put together kind of randomly, and then you meet intermittently, and then they're supposed to help you move along your way. The problem is most did not meet, and most did actually not work very well as far as helping really people get supported, figuring out what they could do to help them move down the path of promotion. So they've changed it, and this last year we call it Mentorship 2.0 instead of 1.0. Every faculty, when they join the department, automatically gets a mentor assigned to them. If they have someone that they wanted to work with instead of that, then they can switch, because this is all about support for them. And there is a meeting that's required every 6 months. So me as a mentor, I committed that I will meet with my mentees, which I have a couple, every 6 months, and there's a form that we go through that talks about what are their clinical areas of interest, what is their activity been in the last 6 months, where do they feel like they need further development, where do they need support. It's a way of helping people get on track and then stay on track, rather than having the 11th hour, like, I'm due for a promotion and I haven't produced anything in 3 years, this isn't going to work. So this is a way of trying to improve the mentorship. And so far, I think it's been successful. This is just our first, we're now 7 months into it. We created this as a result of the person who oversees our education for our whole department. A survey went out, and mentorship was one of the things that clearly was identified by the faculty as an area that we were not doing well, and that people felt like they needed more support. So this is a next iteration of how we're going to try to provide support for people. The other thing that's very important is you have to get people promoted, because it doesn't work well if your department doesn't promote people. And you have to get people to do what the university is asking, right? You can cash in on the currency of the university, but the university is going to ask for something in return, right? They're going to want you to get grants. They're going to want you to publish. They're going to want you to carry forth the name of the University of Washington in an appropriate way at venues in regions, both regional and national, potentially international. They're going to want you to become involved in committees that are driving the care that we provide for patients. So they're going to want you to do those things. You have to make sure you get the criteria and that you review it often to make sure you actually are doing the work. Spinning of your wheels is not a good thing to do, which is hopefully what a mentor is going to help you prevent from doing. And you need to set high goals so people meet them. People will meet whatever goal you set. You set a low bar, people will shoot for that low bar and they'll meet it. So you want to make sure that you have very high expectations. So you're actually developing and promoting a very well-trained, highly skilled group of clinician educators, because those are the people that are going to improve the education of medical education overall, for residents, for fellows, for medical students, and also for each other, right? For teaching colleagues as well. The other thing it's important, I think, in promotion is developing a sphere of folks that you work with outside of your department. We all know that our departments have their blind spots, and you need to have people that you collaborate with that look at things from a different way. So we have an opportunity to work in other spheres allows you to do that. So this is the final part I was going to cover, was talking about the importance at the culmination of the clinician educator is that you actually have someone who gets promoted and does good work. And Jesse's going to come up and wrap it up for you.
So we've done a couple of things. So we started, right, with talking about medical student mistreatment and thinking about sort of newer reasons why this might be continuing in the same way. We've gotten to a place of where we're thinking about how can we intervene and how is teaching needing to change. And we're talking a bit about how it's really now something that needs to be invested in deliberately. That it doesn't cut it anymore to say, this is how I've always done things, this is exactly how I was taught, it's always going to work in the future, it's just enough for me to show up. That it needs to be a deliberate, specific practice. And that I really, Heidi and I talk about this all the time, that we really firmly believe that this is something that you'll get out of what you put into it. So that when a department really firmly supports education, as education is something that matters, then that will become something that will grow and continue to substantiate itself and continue to see other benefits and returns in the future. So at this point, we wanted to open it up and ask for any questions. There's a microphone that will go around. If you are a loud, boisterous person, you can shout. Whatever works well for you.
That was music to my ears. So the presentation and the elevating education. Were there things that you noticed about your mentorship? Maybe I'll direct this to you, Heidi. The peer mentorship among the faculty program and for the residents. Were there pitfalls or challenges? Did you have problems with people making time for this? Or how would you, what barriers did you have to overcome?
I think a couple of barriers. First of all, there was an original peer mentorship group that formed that wasn't chaired by one person. It was kind of a group got together, and what it essentially became was an unfocused group of people who got together and kind of whined about how hard things were. Not very productive. I think they got some publications because they collaborated some, but there was really no focus, no agenda, nothing that kind of kept things moving forward. So I think that's one of the pitfalls. I also think you have to be very cautious in selecting a mentor. Just because you like someone does not mean that they're going to be a good mentor for you. You have to really think about who is this person that is going to help identify my strengths, identify areas I need to develop, and give me a way, a map to move forward. So I also think sometimes people didn't do well because they picked a mentor that they enjoyed working with, or maybe someone that had a similar interest, but sometimes it's okay to have someone with a dissimilar interest that they'll make you think in a different way. So I think that's the other thing, just being cautious and then being realistic. If a mentee-mentor relationship is not working, what you need to do is break up. And it's a no-fault breakup, right? This isn't productive. You need to find a different person that's a better match. And I think both the mentee and mentor have to be completely receptive to that.
Dr. Jensen?
we are in the midst of a mighty struggle to get a new department chair. How important is it that the chair be interested in each of us as faculty?
Do you want to start first?
So I think that, so we've had a pretty recent chair transition in our department. It was 2 years ago. And I think that it is really essential that the chair be supportive of the idea of education, and then at least has appointed somebody who's really good, who the chair listens to and can be very supportive of the faculty. So our chair does not have time to interact individually with our faculty, and has actually really empowered our vice chair for education to do a whole lot more, which is why our mentorship program has really grown and changed, why things have become much more refined and structured in terms of peer mentorship, and people are much more aware of what they need to do. And I think that junior faculty will be much more successful because the chair was smart enough to recognize that this was something that he understood the value of but did not understand personally himself, and he selected someone and invested in someone who can do that work for him. So I think that the future chair does not necessarily need to be able to go to bat for each individual person, but needs to be able to support those who will go to bat. And you know, it would likely, this depends on the size of the department and sort of other investments and things that are happening. And our current chair is very supportive of education in general, but is not in the mix of our Clinician Educator program, and that works just fine. And frankly, our previous chair was more in the mix but was never around. And so it was just much less successful.
And I'll add, with the new mentorship form that we have, the chair is going to review every single one of them. So he's committed to doing that because he wants, part of it at the bottom of the form is areas that you're interested in, because sometimes he is aware of opportunities that might come up that our Vice Chair of Education may not be aware of. And when he first came on, he tried to meet with almost everyone, which was pretty stunning. So we have like 270 add something clinical faculty, as a way of trying to get a general pulse of the department. But I think they either have to be personally committed to it, or they have to understand the value and identify someone within the department to kind of do this good work.
That was a nice talk, and I was glad I attended the workshop yesterday, and I think it was a nice segue because I asked you the question about how do you teach teaching track faculty, how to teach, and that's, so thank you. And to just repeat, yesterday when we attended the workshop, I had asked this question about how do you train teaching track faculty to teach, because just signing up for an academic health center to work, you're obligated to teach. And so how do you do it in the right way, the professional way, the most useful way for your students and for your peers and stuff. And thanks to Kaz, I think we have a similar program, a similar track that we are following. She has started a peer mentorship group for the teaching track faculty. I don't know if you have had a chat about that or not, but that has been helpful. I think we're still working on formalizing it, but that has been helpful for me to find that support and not to feel miserable alone. But you have had some more experience, so I just wanted to know, how do you protect the teacher's time, and how do you value that time? Is that in financial dollars, or you give them credit, and how do you carve out the time for them to be doing the teaching activities?
Sure. I think that you have to have good relationships with your administrators. So I run the outpatient mental health section at the Seattle VA, and so I have, I think, 60 providers or something. And I have to be very aware of what different demands are going on for different people working in the different clinics that I supervise. They have to be clear about me understanding what's important to them. And so I think that the dollar signs are never going to make direct sense. You're never going to see this directly on your balance sheet as a net gain in terms of the time that you're devoting to teaching. But you need to have your clinical administrators understand that the indirect benefits are really significant, right? This is a recruitment tool. We're going to get even better faculty. It's going to enhance our residency education. We recruit directly from our residents for our current faculty. So if we make better residents, we have better faculty. That will increase the productivity of our department. It will enhance our respect. If our medical students have a better experience, it will improve the medical school ranking. That's something that you can work on and advocate for to the School of Medicine. So I think that it's being clear about what the interests of the other side are going to be, right? So it is really helpful when I'm talking to somebody in my section who needs something if we can both be clear about what each one of us need, right? So it's not just advocating for my own interests as an educator, for example. It's understanding that the department has a limited set budget for this, and so how can I make it more efficient? What is this? How can I make this more sense for you? So I think it's really developing and enhancing that relationship there so that they can get what you need and where you're coming from. Will make it much more likely that your needs will get met.
I don't think I have anything to add.
Thank you.
Thank you. That takes lots of time.